There we go. Good. And I'm going to layer it out, you know, basically with a lot of the book and prep work that I'm putting on here. I'm not really focusing so much on the manipulative techniques themselves, because it's best to kind of do those in courses, but it's a bit of the back thought and theory and some of the prior course discussion work that's gone on these different areas. So just this past week, I put up one on the Fib Motions and Assessment, and I'm going to expand this out a little bit more. But Gail did some very nice in-clinic presentations for these recordings a while back. So her Fib one I put up as the first section, which I just put in front of Eric's surface anatomy palpation, which is second. But I figured since the Fib joint is technically above the ankle, I'd pop it up on the top. So again, this could be a hard presentation to watch early on. You don't need to get all the details of it. I'm actually going to do it again, and I'll write down notes beneath this presentation. But it covers this joint kind of succinctly, where she'll go over her assessment technique and manipulative techniques. But again, Eric will cover this in detail, and you'll get it again on the course. So don't feel like you need to memorize this. This is a nice pre-course review, post-course kind of make sure I've got it. A table of contents in there. Next, Eric, there's a nice one with Eric doing surface anatomy palpation, which you'll get a chance to relive in the coming weeks. But it's a good way to kind of review it and just make sure you're kind of clean with surface palpation. And again, I kind of bumped out some of the sections that we had, or Fred's discussion on supination, kind of pronation. These terms are tricky because they're used, you could be talking about supination, pronation in the rear foot, midfoot, or forefoot. But Fred kind of goes over just the basic concepts. Jim actually talks about how when you watch somebody do the rotation test, how it could be inversion, eversion, or supination, depending on what the foot's doing. So don't let this one confuse you. Eric can kind of help clear that up. But it's just a nice paradigm when you're watching people. You see, hey, this doesn't look like clean pronation, or it looks more like inversion, eversion, then it probably is. So we'll cover that. And again, I put in, there were two nice videos just on the dynamics of these joints, motions, and axes of motions. Jim put in, one of the first presentations was one on the biomechanical axes, and he was referring to the shoulder in his examples. But here in kind of this one, they'll cover the biomechanical axes of the subtalar joint in there, and how you can see how it kind of translates. And what Eric will probably also cover is that alterations in these axes can alter how this joint operates. We covered a bit of it last week. But just so you know that you have these review videos that are in here, there's some nice resources out on, even on YouTube. They cover a lot of the biomechanics on these. And I found these when I was trying to get just a better description of what's happening at the subtalar joint. And that way, if we have this down, when you're in course, you can spend more time on clinical translation of the information, less on trying to get the concepts of what is going on. And again, from there, I have this up this week is ligamentous stress testing, talocrural joint motion, and then again we'll go into subtalar joint biomechanics and assessment. And I'll load in this week going down the foot in just the talar bones and some of the other techniques for evaluating and manipulating down the foot. And then I'm going to start uploading elbow probably this weekend. I'll probably putting some elbow prep videos up for you, just to give you kind of a quick overview of how I'm just going to put this information out. I'm going to kind of try and layer it by body part. If anybody, Jen, has any input, I'm more than happy to hear it and kind of adapt to it. If something we can do can help you, better understand it. And again, what I'll probably do is put some of the manipulation in videos after the first course goes, and not focus on that as much, because you don't really need to have a mastery of those techniques ahead of time. But a good foundation is really what we're looking for. I will also put up a reference list probably this week as well, because I've been updating the reference list, and I'll put that up in the main section of the thing for you guys. All right, pull up here. Okay, good. If not, I've seen that some of you, few have viewed the presentational weakness that Jim did, and some other people haven't seen it. I'm going to switch my screens real quick. I'd asked Eric also to kind of, if he was around, to also kind of go over that presentation. I think the presentation Jim put out on weakness, if you do an oral practical with Jim, then these are core concepts that he works the oral practical through and around, and he runs you through these back and forth to cover all the bases. So it's a good starting point to think about what his last presentation was in those 3 slides. And this is a good one to go to, probably even to go back to when you come past module 8 and you're also prepping for the final, because in Jim's module 8, he'll run through these a lot in these thought processes. It may seem a little bit new today, but I'm going to kind of go through them so this presentation, you know, makes sense to you and you kind of get these concepts. Eric is very good at teaching these, so he'll cover them well in class if you can get them.
Hey, Dave.
Yes.
For the slides and things like that would be important or beneficial to go over. Are these things that we can get in a PDF?
I don't necessarily have it in a PDF, but I made a Word document here and I can kick it out to an email where I took his 3 slides.
Yeah.
Pulled them in here into a PDF so I can have them in a note format. I can send them out to you just so you have them kind of clear.
Yeah, no, that would be great.
Okay, I can do that. I have a feeling that would be helpful. The first one I was able to cut Jim's face out of, but you have to live through it in the other 2. So just kind of, as long as you're okay with that, then you can have these PDFs, these files. I don't see Eric up here anymore. He may have ducked off for a minute. So let me go on. And Jim, this presentation, it really looks at, looking at different types of weakness that occur. And this is kind of, kind of a hallmark thing. So, if we get into somebody with, if you think of a neurologically based weakness, Jim's going to break it down into like these subcategories. You have radiculopathy, you have neuropathy, AXT fast flow compromise, and he's going to go into a central weakness. AXT fast flow compromise is probably the one you're not familiar with. It's a bit of an older concept that pops up here and there. But it's also related to disruption of axoplasmic flow of nutrition in the nerve. And you can almost think of this as what you see when you have mild compression for a long period of time on a nerve and it doesn't get good nutritional flow through it. We'll go through this in a little bit more detail in the other slides. But whenever I'm doing an oral practical, that's exactly what I see with given a case history is can that individual then kind of be able to maneuver through these different types of weaknesses that come up with their hypothesis that they can test. So you can think of neurological weaknesses coming from neurological, sources, from nerve sources or central sources. Neurophysiological sources of pain, you could think about being a bit different. Neurophysiological is going to be in that category of your pain inhibition, your segmental facilitation, another topic you don't hear much on that we'll cover a bit, and reflex inhibition. So I don't know. I think let's do it this way. Let's make it the audience participation. Dylan, I see you out there. What would be an example of pain inhibition?
When you have pain from a source so let's think of like trying to test a test of a muscle. Mm-hmm. If you're going to do a main muscle test of something and they have pain, and all of a sudden they don't have that strength anymore. That arm, let's say you're doing like a biceps test and you go to strength and all of a sudden it just flops and it's extremely painful. Mm-hmm. That's what I think of. Pretty straightforward.
And at that point, what would you think about? What would be your differentiations then? Because test the muscle and it's painful, what are the things you would think about would be the potential causes of that at that point?
You have some sort of injury to the tendon or the muscle itself.
So yeah, now we're down into the structural one, the category below, which is your macro tear or degenerative tear, or again some point of injury that way. We have acute pain, whether it be from a damage to the tissue, neural structure, you have pain inhibition. Okay, what is your ankle sprain? Okay, you sprained your ankle back in December, and you come in the clinic, go in there, they go and test your everters, and I'm breaking through you consistently, and your ankle is weak when I test it. What is that considered? Old sprain, you're healed up, you're running again.
Is that more reflexive inhibition?
Yeah. Hey, Eric, feel free to chime in. I'm covering Jim. I think I sent you the notes on presentation, so feel free to add to this as you do. Yeah. So, that ankle sprain that, that has been there for a while, could be reflex inhibition. It could also fall under potentially a segmental facilitation as well, because pain and nociception can create that as well. But most commonly what you'll see after pain inhibition would be a reflex inhibition that occurs thereafter. And the easiest example I have of that is that ankle sprain that you see, where classically 6 months later, they have inhibition in the ankle. And you'll see that data kind of shows that those individuals too have a higher incidence of lower extremity injuries in the following months as well, due to the reflex inhibition that's been left over from that. Any thoughts on that ankle case on reflex inhibition or pain inhibition, Eric?
Well, I mean, just looking at the causes of reflex inhibition is typically due to poor mechanoreceptor feedback to the muscle tissue, right? So it versus something like a facilitation where we're dealing with kind of a descending control of that sort of mechanism. This is more of a local problem, right? And so that's why we tend to see this very consistent weakness versus something that actually depends on speed or something that's fatigable, that sort of stuff. So you have to really think about what structure it is that's damaged and where you're getting that kind of feedback loop failure. But that's very common with reflex inhibition.
What's another area you commonly see this happen, Eric?
I'm sorry, say that again.
What's another area you commonly see this happen?
Probably the most common other one is around the hip, mostly because of the UFER, right? So, or some sort of arthritic change. Now, arthritic changes can be a little bit different because you can have actually the change in the actual joint surface. So the actual space within the joint has altered the levering mechanism. So it's more of a leverage problem than it is something, affecting true mechanoreceptor input. But not to say that, an arthritic change or an arthrotic change, I guess I should say, wouldn't cause reflex inhibition, because there had to have been some sort of damage to that surrounding tissue to begin with. But you just have these two things kind of piling on to each other. But the hip's probably the most common other one. We see that very consistent loss of strength in the hip external rotators. And then you can check any of the others, hip abductors, hip flexors, they'll all end up being weak to some extent.
Mm-hmm.
I see it a lot more consistently in the lower extremity than the upper extremity. I just tend to not need to look for it as much in the upper extremity. But you can certainly find it in the wrist. You can find it in the elbow. The shoulder is a little bit harder to really diagnose it with because of the influence of the shoulder girdle itself. So you'd really have to be very specific in how you're testing things around the shoulder in order to make sure you're not finding weakness due to an AC joint issue, an upper thoracic issue, which is, it's not really in our curriculum, but I tend to call that more of a regional inhibition as opposed to a true reflex inhibition, right? Because typically you consider a reflex inhibition something that's affecting the local joint, right? So for the everters, because they cross the ankle joint, that's why they're affected. But when you're looking at testing shoulder abduction, doesn't necessarily cross the shoulder girdle per se, right? It doesn't attach to the trunk, but you'll still find weakness because you have a hard time anchoring there. But the presentation is exactly the same, very consistent, very breaking weakness of that type of musculature. So it's a little more unique in the upper extremity, especially around the girdles, I tend to think, because of the mechanism anchoring to the trunk.
Yeah, I mean, that's well put, because you're absolutely right. It doesn't limit itself just to the glenohumeral joint, because your scapulothoracic function, there's multiple structures that can cause it.
Sure.
So I think about that as being a regional inhibition or change in cortical motor pattern,
yeah.
Which is, you think this reflex inhibition, it's kind of been taken up with more recent research. We're looking, okay, the changes that occur in the cortical patterning are also altered, and that they also need to be rehabbed after you've had a period of time of pain inhibition or reflex inhibition. Then you have the cortical drive that comes in, which is a kind of another layer. So there's interesting thing. I see it creeping in literature more and more. I think as transcranial stim starts to kind of be used more used more in research settings. Yeah,
that's interesting stuff. I actually have one of those here in the office, and I've used it a few times. It's interesting how it works.
Are you a transcranial stim?
Yeah, it's just one of those halo devices.
Okay.
It's actually the earphones, but it's entertaining.
Oh. Are you getting information from it or using it for treatment?
I haven't gotten to use it enough for treatment to really know. I just got it not too long ago, so I haven't really delved into the actual numbers on it yet. But it does track everything because you have to do it through your cell phone.
Okay, that's interesting. I didn't know the market. What's the brand?
It's called Halo Neuroscience.
Yeah,
It's the most comfortable thing in the world. It's got these little knobs on it. Look at this thing. All these knobs on the device here that dig into your head.
Yeah, say there was something to kind of go in. That's interesting. I didn't realize they were making a reasonable clinical version of it.
Yeah, it was about $300.
Geez, yeah, it's in the world of medicine. It's basically a bargain.
Yeah.
But that's kind of, where you look at the literature now, and the article on pain mechanisms and manual therapy. That was the big update they did from they did an article 10 years ago and updated it. And some of that science is the newer things in there. If you want somebody good on that, Ebony Rio does that research on tendinopathies. And she's out of Australia with Jill Cook, I believe. And she does a good bit of work on that too. And it's very, very interesting where they look at cortical drive and timing and tempo as far as tendinopathies, and for that being the dysfunctional area. That's kind of in this subcategory of reflex, what's left over from reflex inhibition, or is this more just from the cortex?
Yeah, it seemed like an interesting thing to trial for the price anyway. It's an interesting thing to trial for neuro re-ed, retraining motor patterns. It's basically you wear it for about 20 minutes before trying to get into learning a new task or relearning a task. The thought there was they wear it while I do my hands-on stuff, and then we head out into the gym and we do some retraining stuff. It's had some significant results, I think. I mean, it's hard to say from one person to the next if you haven't done retraining without it, but at the same time, anyway.
Halo Neuroscience, yeah, look it up. Okay, the next slide, Jim talks about, he breaks this out in nice detail. And again, I recommend, you go through it in the weakness one as well, because again, this is essentially kind of the hallmark of what, if Jim does clinical, Jim is thinking about doing, he wants to change the exam format to do a 30-minute clinical reasoning session. It's probably done by Zoom, and then do the oral practical. Is what Jim has been trying to kind of talk about doing. So that said, if Jim ends up doing these 30 minutes clinical reasoning practicals, this is basically what Jim looks for. He looks to take you kind of through a ride through basically this chart right here, which looks a lot more confusing than it's going to be at the end of this next 40 minutes. So this is Jim's causes of weakness. So you get a case, and let's move over to the right into neurological. Okay, you have a I don't know, let's make it a 45-year-old patient with, basically deltoid weakness and atrophy. What do you think this would be? Let's play pick on the fellows. Which one of you are out there? Don't make me pick you. Tim, you're out there, buddy. What do you got, Tim?
Sorry.
You have deltoid, you have deltoid weakness in an individual and atrophy. What could be the potential cause of isolated deltoid weakness? This is a Jim oral practical question, actually.
Oh God.
Let's look
Probably
at
a peripheral neuropathy of the axillary nerve, potentially.
Yeah, because what else does, what else would, if you have a C5 or C6, what would you expect to see?
Maybe a little bit of biceps, even going into the external rotators. I mean, you're going to see other patterns that it wouldn't be isolated to just a deltoid. So,
So what would cause a weakness like this?
maybe like a. I'm not 100% sure.
It's okay. Throw a couple things out there. You can ask a friend.
A lesion to the neurocyst to the nerve, maybe.
Yeah, lesion to the nerve. So it could be a traumatic lesion.
Yeah.
You have a mononeuropathy. What else? This person just came back from, I don't know, Vietnam a little while ago. This is bonus points, Tim.
Agent Orange? No.
It was a little late for that.
I'm going to phone a friend.
What else would cause that?
Oh, kind of compression to the nerve.
You have compression to the nerve. The one thing you may look for in here could also be at this point, you're looking for central things. You're also looking at viral.
Okay, gotcha.
In this one, in this exam, Jim was actually looking at, basically, okay, what was the viral cause of this as he took you through. And kind of what you'll have to do in that exam is kind of think through, if I have a peripheral nerve lesion, because you were on the right track. You're looking at a mononeuropathy. You don't have crossover of other segments.
Yeah.
Okay. So you're kind of saying, okay, well, if it's multiple segments, you'd be thinking of radiculopathy. So those types of hallmark things kind of help you figure out, okay, what do we have going on here?
Okay.
Sorry. I think I lost my grid here. Let me stop sharing, come back. So peripheral neuropathy. So okay, it's a 39-year-old patient with pain down into the foot. Tim, what would you think now?
Pain going into the foot? I mean,
Yeah.
Probably more radiculopathy if it's kind of.
How would you determine the difference between a radiculopathy and a peripheral neuropathy?
Kind of look at distribution of the pain. Does the spine influence the pain at all, or pain or the symptoms? The spine movement, maybe.
How would this person be different in your exam? What would you expect to see on the examination?
You look at the pattern of the weakness, maybe. If it's a L5, it would be everters, maybe even hip external rotators. But if it's a peripheral nerve lesion, then it's more likely, probably the lower leg muscles of the whatever foot muscle is affected. So
you think if we have a neurological lesion, how does a radiculopathy look different than a peripheral neuropathy? Sensation. How is sensation different between the two?
Oh God.
Come on, Tim. You can do it. Dylan can help you, but he's not going to. It's just the way Dylan is.
I
know it's hard to be on the spot. Think about it this way. What would the borders look like? When you have a radiculopathy, are there nice clean borders?
No, not at all. Peripheral neuropathy would be clearly defined, I think.
Yeah, you're looking for a clearly defined border in the distribution of a peripheral nerve. Would you have hypoesthesia or anesthesia?
With peripheral neuropathy, anesthesia.
Mm-hmm.
No. Yeah, anesthesia for peripheral and hypoesthesia for radiculopathy. So.
And why is that, Tim?
Just kind of the overlapping. I'm going to say multi-level innervation with the nerves versus, peripheral neuropathy is just that nerve. So,
how about reflexes?
Be hypo with radiculopathy. With peripheral, probably be absent, I think.
Yeah, peripherally. Yeah. So, with those things, you kind of, now let's say this was, now what would a central lesion, it's called disease, let's say, how would this differ if, okay, you have this going on, and this was a central lesion, this was being centrally driven?
Hyper reflexes, increased reflexes, maybe even increased sensation. Positive Babinski.
The upper motor signs.
Yes, exactly.
What else? Anything else in there, Eric, that you can think of differentiating between these? If we're looking at peripheral neuropathy, radiculopathy, and basically, the two of those.
The axillary nerve gets to be a little dicey because there's about 10% of people where it doesn't supply sensation at all.
Yeah, but we're more in that's why I took it to the lower extremity, because we didn't have the sensation. So we just kind of went down to, okay, pain radiating down into the foot.
Yeah, I mean, looking at upper motor neuron stuff, you'd see your typical stuff, right? So you'd see long tract stuff, you'd see Babinski, Clonus, Hoffman's, all those sort of things should be present.
Mhm.
You know, differentiating peripheral to a radiculopathy, you know, in theory, you'd be able to affect some of the symptoms with movements of the head and neck for radiculopathy, right? So you should be able to make them worse or better in theory. You know, again, it's kind of tough with the axillary nerve, but I mean, that's kind of the stuff that you'd look for is, you know, can you affect it centrally versus something peripherally?
Yeah. And how would you just, Eric, how do you describe when you have axoplasmic flow compromise?
Well, exoplasmic flow, I mean, essentially it's another neurological mechanism, right? So the difference is that radiculopathy is affecting the conduction, right? So the electrical impulse. Axoplasmic flow affects the flow of the neurotransmitters, so it affects the synapse more so than the actual electrical conduction. So they're very difficult to tell apart initially, but you'll tend to get secondary symptoms with axoplasmic flow problems. So looking up at the upper left corner of this chart, you'll start to get some slow flow issues, which is the degeneration of the end organ. But again, axoplasmic flow, depending on where the compression is, because this is what we tend to think will cause axoplasmic flow problems, is some sort of moderate compression of a nerve. You would tend to have more of a peripheral distribution of this sort of issue, right? Unless the axoplasmic flow issue is actually being caused by mild compression of the nerve root itself. But at that point, you'd also expect to have lancinating pains, right? Because now you're actually impacting the nerve itself. So you'd actually have more true sciatica type symptoms or lancinating pains into the upper extremity. With a peripheral lesion, you don't tend to have that sort of thing unless there's significant friction and inflammation involved.
So yeah, so the axoplasmic flow on this is what you're going to see is that it's a mild compression of the nerve. So it doesn't look, it can be similar to a radiculopathy in that, okay, you can also have fatiguing weakness because of the loss of neurotransmitter at the end organ. But it's, you know, Jim kind of talks about it in the video as being, this one is a bit more modifiable. So if you think about that peripheral, okay, you have a radiculopathy, you see, but then now all of a sudden you do neural mobs, or you do cervical mobs or peripheral joint, you know, work or soft tissue work, and you see it improve, you know, within a session. So you could have in there a segmental facilitation can work the same way if you mobilize centrally. But with these, you know, those are the ones where he talks about, these are the ones that probably respond very well to some of those treatments. Whereas your pure classic radiculopathy where the nerve's been compressed and damaged and needs a cycle of healing, those are the ones that don't really respond as well to some of the interventions. Would you agree with that, Eric?
Yep, absolutely.
So that's that gray area between, you see these ones where it's like, oh, this person does really well with this intervention, and then this other classic radiculopathy doesn't. It's really differentiating. Okay, where are you in this neural compression continuum? So they talk about these axoplasmic flow. And I don't see much of this in literature. Do you, Eric? I don't see this, you know, this is an older concept.
No, I mean, unfortunately, it tends to be very forgotten because most of the medical literature just deals with pure compressive stuff, because most medical literature doesn't deal with traction injuries either that can cause radiculopathy. You know, so we have to be kind of aware of that sort of thing, because you could have a situation where you actually have a nerve root that's being pulled too tight, right? And so that's actually what's causing the limitation there. As opposed to something where you're actually getting something impacting it. So it's the same sort of deal here. It's just kind of fallen off the radar. The whole idea of neurotransmitter loss just kind of fell aside at some point, but you still have to consider it because it's definitely still a possibility. The axoplasmic flow stuff are one of the things you'll tend to see that may crop up with like intraneural scarring, right? So if you have a lot of inflammatory exudate around a nerve for a prolonged period of time, it'll actually end up scarring the tissue. If you have prolonged compression, any of these increased pressures around the nerve tissue will actually eventually start to build up scarring, right? So those things tend to affect the axoplasmic flow because it's essentially the very same as like getting a plaque within a blood vessel, right? It's just going to obstruct the flow of those micronutrients going through. Those things you can actually benefit from things like, you know, neural flossing and some of those sort of deals, because essentially what you're trying to do is move the tissue enough to break up some of that scarring that might be adhering to that tissue. So it's a tough sell though, because you tend, and I know as faculty, we tend to try and avoid the idea of doing nerve gliding with patients that are presenting with radicular symptoms, because all we're going to do is take that nerve and rub it against whatever it is that's compressing it. But if you have AXT stuff, it may be beneficial. So you have to look at kind of the chronicity of the problem with that, right? Because the scarring, you would tend to suspect something that's been longer lasting than something that's actually developed within the last few weeks.
Yeah, or what you're left with in the treatment is you're basically, it's a treating peripheral central sensitization through motion. So you end up doing the neural mobs, but you're not quite getting the neural mobility. That may not be the primary treatment mechanism you're getting with somebody like this. Is, are you desensitizing it in central sensitization? And we don't really cover central sensitization. Jim doesn't cover it here, but something we can talk about a little bit because it does fit somewhere into this family.
Yeah, probably with facilitation, but
yeah, you put it there because it's more of a, it's called on a lot more recently, you know, but it's almost gotten too much play in a sense where, you know, I think even Chad Cook came out recently and said, yeah, this is the primary driver and probably well less than 10% of the people you're seeing. So, you know, go back, you know, make sure you're treating musculoskeletal problems first before you jump immediately to central peripheral sensitization as a primary mechanism.
yeah, I mean, the problem with that is with going straight into trying to treat a central sensitization issue is you're just chasing ghosts at that point, because if you don't correct any potential biomechanical faults that are there, you're never going to get the success that you hope for with a sensitization issue. Otherwise, you've already lost, you know, some sort of dural or neural mobility because you're dealing with altered axes of movement somewhere, right? Whether that's peripheral or central, it doesn't make a difference. Eventually, you're going to end up with some sort of loss of movement. We see that. We'll talk about that quite a bit in, what is it, module 6, as we go through some of the shoulder girdle stuff. When we start looking at upper limb tension testing. Because I've had a lot of pushback on stuff like that everybody has some sort of upper limb tension and it's normal and it's not something that you should consider pathological. It's like, well, that makes no sense from an anatomical point of view, that you can get into a functional position where you're actually going to increase the amount of tension on the nervous system to the point where you can cause damage. That makes zero sense to me, zero sense whatsoever. So when you look at studies that start to suggest that sort of thing as well, this is what we found in healthy individuals is we're still dealing with upper limb tension. It's like healthy in that they're not displaying any symptoms, but it doesn't mean that they don't have dysfunction that could increase the tension among that system, right? So it's just it's bad science when you start talking about it that way. So we'll talk about that a lot more probably in module 6 when we go into the shoulder girdle stuff, because things like double crush tend to fall under that umbrella.
Yeah.
But yeah, it's can get confusing at times, but you just have to take care of those biomechanical faults to make sure that there's no extra stress on that neurological system. Once you do that, then you can go treat the central stuff.
Yeah. That's kind of where I thought of AXT in this. It's like a subset under radiculopathy, like radiculopathy light in a way, in the sense that you don't have the nerve damage and compression, but it presents similarly. But your response to this patient is usually much faster. And again, at that point, you're also differentiating. I'd say the next one I differentiate that against would be probably segmental facilitation, which you're going to see would be the closest thing to it. And how do you compare AXT and segmental facilitation, Eric?
I mean, realistically, AXT and facilitation they're going to be two different mechanisms, right? Because when you look at what the responses you're going to get from your neurological testing, and this is why I do muscle testing with almost everybody that comes in for an evaluation, because I think it tells us a lot based on the responses we get, right? So when we have fatigable weakness, we're realistically looking at some sort of radiculopathy, some sort of peripheral neuropathy, or some sort of AXT lesion, right? Those are kind of the three things that would give you neurologic fatigable weakness. When we look at facilitation, it's almost essentially, you don't want to call it the reverse neurologic mechanism, but
yeah,
radiculopathy, those sort of things, these neurological mechanisms, they drop everything, right? So we get hypoesthesia and or anesthesia, we get weakness, we get this fatigable weakness, and we get diminished reflexes. With facilitation, it winds everything up. So we're still going to get weakness, but it's based on increased tone. right? Increased tension going across the muscle belly and across the tendon, probably affecting the GTO. And that's probably why it's velocity dependent, is that speed with which you add the load onto that structure makes the GTO turn, signal the muscle to turn off. We're gonna cause structural damage here, so turn that damn thing off before something snaps. But you look at reflexes, they're brisk, right? They're increased. We get hyperesthesia, right? Increased pain reception, all that sort of stuff. So looking at AXT versus segmental facilitation, they shouldn't be mistaken in most cases. I mean, they're definitely a differential because you have that kind of neurophys kind of basis by which they're both being caused, but clinically they should present fairly differently.
Yeah, I think that patient presents with something going on in the neurophys. It's kind of what you see. It's in this realm. And generally that's where you get into, you're looking at your muscle testing as probably being the one primary that goes to my mind because it's the easiest one to see the difference in. And then reflexes or any type of sensory, changes, then kind of further cements it.
Yeah, and I love the muscle testing too, because it's usually, if you're looking at it potentially for a spinal, issue, some sort of radiculopathy, facilitation, these sort of things, it's where you're levering is far away from, topographically from the source of the pain, right? So doing testing here on the wrist shouldn't affect the neck, right? So you shouldn't get any type of pain inhibition when it kind of comes to that sort of stuff versus, if you're trying to do things with the trunk, it's obviously potentially going to cause pain inhibition. You're going to get a kind of a false positive essentially when you're looking at those sort of things.
Yeah, it's funny. Eric, in a minute, give a case, it's lower extremity. I mean, it's funny, I'm in a tennis clinic, so I see it, and we have CrossFit here, so I see it a lot in the upper extremity. Like my classic one that I see is basically they come in, it's somebody lifting or playing tennis, and it's the C7. So they come in with some type of, thing, and they'll have vague symptoms, whether it looks like a tendinopathy or a wrist problem, and you start looking at them, and that's when you start picking up the weakness. And it's very common for me to bump into the weakness, and the first thing I look for is is it fatiguing? Is it non-fatiguing weakness? And that's kind of where I'm looking at. Am I looking at AXT radiculopathy or some type of inhibition, or reflex inhibition, let's say, versus a segmental facilitation?
Yeah.
And then I may check the reflexes next, and then I'll go into treatment. And usually I'll rule out if they have non-fatiguing weakness. I'm thinking segmental facilitation because that's the presentation with the segmental facilitation, where AXT radiculopathy, they're going to be, probably more fatiguing weakness. Pain or reflex inhibition will probably be in the same family where you're going to have this breaking weakness that's similar.
Yeah.
But it's usually you get to a point and then it's just more of maybe a give.
Yeah. I mean, the breaking weakness to me with reflex inhibition is very characteristic, right? So the most common one that I'll probably see is around the ankle. You put them in a hook line, you pull the foot up and you ask them, hold this, and they hold it for a second and then it just gives out just like that. You test it 3, 4, 5 times and it's the exact same thing over and over again. That's very characteristic of a breaking weakness because your pressure is consistent, right? It's not speed dependent. So as soon as you start noticing that sort of weakness, it's consistent and it's not variable based on how quickly you apply the pressure, it's most likely going to be a local problem. But you can correlate those things very easily because then you can go in and test the everters or the inverters and test different spinal levels, right? So you're looking at everters, you're going to be L5, S1, you're going to go to the inverters, they're going to be L5, but dorsiflexion is L4. You start having the same breaking type of weakness with all 3 of those directional tests, you have to assume it's local. Otherwise, you're dealing with a multi-segmental lesion through the spine, which is bad news to begin with. Anything 3 or more in the lumbar spine is not going to be a good sign. So you should be able to correlate those things by changing the muscle that you're testing, right? So if you're suspicious of it being a segmental lesion, you go and test another segmental muscle, right? So for L4, you'd probably want to go test the either the inverters or you'd want to go test maybe the quadriceps, something of that nature. And then you can go in and do a wobble, right? Just lay them in prone and do a wobble on L4 and see if you can change that feedback loop. If you can do all that, then you're dealing with a central lesion, right? You're dealing with something at that point that is affecting a segmental level as opposed to something that's affecting a local peripheral joint. If that makes sense. Vertebral weakness under facilitated segment. Let's say that on there.
Yeah, the facilitated segment, you would have.
Yeah, if it's in the same week.
Yeah.
It just goes.
Jennifer, are you talking on this page?
Yeah.
Yeah, it does say fatigable. It does say fatigable weakness here. That's definitely a typo.
Yeah.
Should
And
say
also-
non-fatigable.
I'm pretty sure on the video he mentioned and said it should be the opposite. I
Yeah,
think that
it's
one
it's non-fatiguing is the big differentiator, so it's confusing. I'll hit Jim up on that. I don't have the raw PowerPoint video on this one. But he should be able to change the slide. But yeah, it's non-fatiguing weaknesses. That's what we're talking about. That's the big differentiator kind of for Eric and I when we do the muscle test.
Yeah.
That's why as much as we'll talk about, hey, no one does the scan exam, we all kind of use these portions of the scan exam. It has to be clean and you have to have it in your arsenal because this is where you're getting this information from in a clean, specific test to say, is this fatiguing? Is this non-fatiguing? How does this weakness respond? So I can differentiate radiculopathy, AXT, reflex inhibition, pain inhibition is pretty easy. Again, as Jim says, if it's a myelopathy, they're probably not coming to you and you're probably going to pick it up, well ahead of the strength test.
Monday,
Yeah.
if you want to.
I mean, you'll be weak with a myelopathy too, but it's going to be, you're going to get this kind of cogwheeling with it as it starts to give out.
Which one was that, Eric? The cogwheeling?
Myelopathy, so spinal
Yeah.
cord lesion,
Mhm.
upper motor neuron stuff. It's going to look very clonic, right? So if I'm testing my elbow here, it's going to start to give out, but it's going to be more of this sort of thing as it starts to give out, because you're dealing with spasticity at that point.
So can that get better?
In theory,
Yes.
I had a patient that I'm seeing, like I was seeing him last year, that he had a lot of that spasticity that's on screen. And I'm like, you need to go to neuro and get everything like checked out. And like he had like MRIs and everything like that, and they didn't see anything like that. And now he's back and he doesn't have that cogwheeling effect anymore. He's still weak,
Mhm.
but he doesn't have that anymore.
yeah. Well, I mean, in theory, the system can heal, right? So when we're looking at, and I think we talked about this in module 1, where dealing with the different types of nerve lesions, right? There's kind of various tiers of these things, the axonotmesis, neurotmesis, et cetera. The more substantial the injury, right? If you actually sever the nerve and the nerve sheath, the dural sheath or the epineurium, depending on peripheral versus central, you sever that sheath, it's probably not going to return, right? Because at that point, there's no way for the nerve tissue to regenerate back together. There's nothing to approximate it. But if you don't sever the nerve, right, for instance, and it's just kind of like a bruise almost, then yeah, it can heal, right? If the nerve sheath is intact still, then and the nerve is severed, there's still the guide, right? So the tube of the nerve itself can still at least guide that nerve tissue back to where the other end is. Otherwise, you get all this collateral sprouting and the weakness will probably never go away because this connection has been kind of permanently disrupted. So it all depends on the extent of the injury as to whether or not it'll be physically capable of healing.
Yeah, that makes sense. I mean, he just like super weak still, but he doesn't
Yeah.
have that anymore.
Well, and you have to consider, and this is part of the slow flow mechanism for axoplasmic flow. You have to consider the size of the lesion, right? Because of how slow some of these replacement proteins and these structures are able to kind of move through. This is where you hear about the 1 millimeter a day recovery for nerve structures comes into play. That's what the slow flow mechanism is, right? Is replenishing these structural proteins and some of these other architectural mechanisms, right? So when you're looking at that sort of stuff, it depends on how much damage was, locally where the actual lesion is, and then distal to that, essentially how much degradation was caused by the interruption of that slow flow, right? So if he had these issues for several months, you're looking at almost like 3 times that amount of time to get that structural proteins, that get that flow back to where these things are going to be potentially, even remotely nearing normal. This is why nerve injuries are so devastating and why they take so long to recover, is because the way the body replenishes that is through that slow flow axoplasmic mechanism. That's how you do it, yeah, Dave?
Mhm. Yeah.
Yeah.
I mean, that was the other thing I was making. That's also the degradation model with this as well, of why you can have this slow flow disruption that's somewhat of a subclinical, but now you develop the tendinopathy from it.
Mhm.
Because it's
Yeah,
loss
so
of
the end
nutrition.
organ is affected by that too.
So your tennis elbows is Jim's kind of classic example of that. What would you see what do you see in the ankle, Eric? What do you feel you see if you see a slow flow disruption? Where would you describe it in the lower extremity that you feel like you see it?
Oh, probably the most common one would be like a tarsal tunnel affecting the posterior tib, something like that.
Mhm.
Because that's essentially where it gets its nerve supply from. So you're going to end up with potentially rupture of the posterior tib tendon after it gets past the tarsal tunnel. That's probably the most common one you'd find. But it could be, you could have it in any number of things. If the injury is up higher, you could certainly have the stuff that'll affect like a hamstring tendon, something like that. You could have something that'll affect the patellar, quad tendons, and any number of these structures, depending on what level, where the actual impingement, where that actual interruption of that flow is coming in. You could see that quite a bit. I haven't seen this clinically, but you can kind of assume the idea of somebody that comes in that's had a hernia that's affecting the femoral triangle where the femoral nerve will exit through there, right? Getting down to the leg. If you have something like that, and then the most common lesion that will cause interruption there will actually be a hernia. And the second most common cause is the surgery to correct the hernia,
Yeah.
right? So you can have a diminishment of the flow through that vessel pretty consistently, and then somebody tries to get back to exercise too early, and all of a sudden they pop their patellar or their quad tendon as they try and go back to play basketball before they've fully rehabbed and kind of gotten back to the point where that the distal structure, right, the actual patellar structure there is not sufficient enough at that point, because we haven't given it enough time for the slow flow mechanism to kind of reintegrate that protein synthesis around those structures, around the collagenous structures there. And it's just too weak to handle any type of ballistic load. Is that all good? I'm not talking over anybody's head, am I?
It's essentially the loss of nutrition to the nerve and the end organs decrease its output, and that's where you're going to have, it's going to break, that tissue will break down due to that decrease in tone and that decrease in neural stimulus. So you don't necessarily have pain. What you have is, failure of the tissue structure, whether it's an elbow tendinopathy or, it develops in the quad or the posterior tib from that slow flow disruption. That interventions we could talk about a bit, Eric. It's reflex inhibition. How do you test and retrain reflex inhibition?
Well, you got to put, first thing you got to do, you got to put them in a functional position, right? So for me, looking at the ankle, you have to have them in weight bearing, right? So we see a lot of therapists in general that will do a lot of proprioceptive type mechanisms where they say, close your eyes and I'm going to move your foot, or I'm going to move your toe, or whatever it might be. And you just need to tell me if I move it up or down, left or right. Those are proprioceptive mechanisms, but that's a feedback thing right there. That's a centralized proprioceptive mechanism where you're actually getting it up to the higher centers. That's not what we need. We need the reflex mechanism to be the one that we're triggering. So the easiest way to do that is actually to stimulate the mechanism that you're using in weight bearing. And the fastest mechanism for that actually isn't proprioceptive. It's actually somatosensory, right? It's pressure reception on the bottom of the foot. So in standing, you'd have them do single leg stance. Then you'd have 3 different ways that you'd want to kind of associate this. You'd want to have, because there's 3 different mechanisms for balance, right? We've got our eyes, we've got the somatosensory feedback from the structure that's actually attached to the ground, which would be the bottom of your foot. And then you've got the inner ear, right? So you want to take these and you want to try and isolate them individually. So you have them stare straight ahead, eyes open, right? Most people are going to use mostly the level of the horizon or the wall or whatever you're looking at to kind of use as their primary method for establishing balance in the vestibular region, right? So the next thing you do, you'd have them stand 30 seconds, then you'd have them close their eyes for 30 seconds. Okay. You take away that visual cue and you have them focus on the pressure where their weight is over the top of their foot, right? So you get their foot on the ground and it's going to very gently kind of shift side to side. It's inevitable, right? You're just going to get that from the beat of your heart, from the movement of the earth, all of these different things. And so you're going to get this kind of gentle sway, but if you can actually get them to focus on that sort of thing, the body will start to pick up on that feedback loop, right? And essentially, as soon as your pressure starts to shift, say you start shifting more medially toward the medial side of the foot, the reflex mechanism should be very quick, right? It should be here. It shouldn't have to go through the higher centers in order to fire the particular muscle that you need to self-correct that balance. After that, you want to start taking away some of the vestibular feedback, right? So we'll have them open their eyes again and then start turning their head side to side, right? So it's going to stir the vestibular loop, but it's going to also blur the eyes, blur your vision. So essentially at that point, all you're able to rely on is that somatosensory feedback through the ankle or it's actually through the bottom of the foot, right? So talking about things like Ruffini endings, Pacinian corpuscles, Meissner's, and what's the other ones that I'm forgetting? Merkel cells, right? So these are the Pacinians and the Ruffini endings. These are the fast adapting ones. These are the ones that are most integrated with things like balance because they react at about 400 hertz per second. So you can get very good fast reflex feedback out of those sort of things. Now that's what I would do for the lower extremity, and you can certainly use the same sort of mechanism for a knee issue or for a hip issue. All you're trying to do is stimulate the musculature around the essentially injured area in order to relax. Now, if you're doing the hip, you're going to probably want to put them in more of almost a forward bent or more of like a half squat position. So you focus more on a hip strategy as opposed to an ankle strategy. But it works just as well. The whole idea here is just remove some of these other feedback mechanisms that are coming from the higher centers. Quadruped. Well, in quadruped, you're going to get a lot of feedback from the shoulder girdle too. So you could probably do it in kneeling if you'd like to. The difficulty there is that you're losing much of that somatosensory feedback, right? Because you're not going to be in a kneeling position too often. Certainly not in a single leg kneeling position. I mean, you could be in like a half kneeling or genuflected position for certain things, but it's not as functional as being in a stance position. Certainly not for gait. So that probably wouldn't be my first choice. You'd want to put them in more of a half squat position, just drop the knee so it's at about a 30-degree angle. That'll give you plenty of feedback through the knee and through the hip. So that's what I would do for the lower quadrant. I don't know what you would typically do up there for the upper quadrant, Dave, since you're seeing more of that than me.
Yeah, I mean, generally it's the same type of thing. I think with balance and proprioception is where you're going to be in the lower quadrant. Upper quadrant is the same thing. It's patterning of movement and timing. I think, you touched on the one concept with inhibition is that there's the local segmental level that occurs to it, or the somatosensory portion of it. And then there's the cortical level, which we talked about, the cortical drive. And you differentiated it too early on in there is, okay, you want to kind of, cortical drive is one area you treat, but you treat the reflexive patterning of that, differently. So it can just be reflex reaction times of things, bouncing, catching balls, just doing things, just trying to speed up the nervous system. But again, there's also that feed forward mechanism there as you overlay on it. But it's funny, I'll do more of that deep balance type thing, lower extremity, because that's its function. Upper extremity is just more about, patterning and treating what maybe the cause of, okay, we're talking about reflex inhibition. What's the driver of the reflex inhibition? Is it just leftover residual from a prior injury? Or do I need to treat, something that's perpetuating this? In a second. Facilitated segment. Got a couple minutes here. Facilitated segment, that's the one I think I see. So like a lot of times you're going to see these individuals and you're thinking, okay, reflex inhibition, facilitated segment, both have a bit of a fatiguing or breaking weakness. With the facilitated segment, you may have centrally mediated things with the skin scratch test. You may see the reflex changes as well, being a brisk reflex. sometimes it's falling in this netherworld. So between facilitated segment, reflex inhibitions, as Eric said, it's, do I have multiple, neurological levels across the joint? If it's an elbow, is it the flexors and extensors? If it's the ankle, it's in multiple directions across the ankle, which shall be facilitated segment. And there you're looking at, their treatments in the lumbar spine versus at the peripheral joint. So I think Eric alluded to it with the facilitated segment. My first go-to would probably be the wobble, because it's quick, it's easy. I can do it right in the middle of my eval, and then I can come back and retest them. I use this as probably one of the best marketing tools that are out there, because if you have a C7 non-fatiguing weakness and I can blow through their arm every time, I taunt them a little bit, tease them, then I mobilize the neck. If I come back and they have 5 out of 5 strength, they're wondering what the hell you just did. And now what I have is street credit for the next couple of visits.
Yeah, they'll let you do pretty much anything. The worst one I ever had, Dave, I think I told this story in module 1, but I had a guy that came in with lateral elbow pain, and he'd seen a dozen different people. He'd seen doctors, he'd had surgery on one of them to do a release and all these sort of things, and he was just miserable. He came in just not at all thinking that PT was going to help, and I'm looking at him and I'm just like, well, just from the description you're giving me of this problem, more than likely the problem's not actually in your elbow. More than likely the problem's more central. It's probably coming from somewhere in the lower neck. Did not believe me, none of that sort of stuff. He was a pretty big, thick guy. Like his biggest issue was he couldn't get into the gym anymore. And so I was just like, well, I tell you what, just because he was being kind of snarky with me. The one thing that I can guarantee you is if this is coming from the neck, and I do a typical treatment that you should do for an epicondylitis, which is a cross friction treatment, right? A
Hey, how's it going?
localized
I'm
treatment.
just finishing up a Zoom. Do you want to start off on the bike?
Yeah, he does.
How's your knee feeling today?
I think it's good.
Going good. Yeah.
Isaac, we hear you.
Oh, sorry. Thanks, guys.
That's fine. That's fine. So I told him if I do this cross friction treatment on it, it'll actually make it worse, like substantially worse, right? Because what causes the facilitation? It's abnormal nociceptive input, right? So even if I'm doing it peripherally on this damaged tissue, it's still going to get back into the reflex loop, right? It's still going to shoot up into the reflex loop. So it's still going to make those things worse. So I was like, if this is a local problem, it'll make it better for at least a couple of days. If not, you're going to feel like crap tomorrow. And I'm like, but if you want, I can prove it to you that this is actually what's going on. He said, okay, have at it. So I, did one of the arms, and he was so miserable the next day. He came in just like, just fix the damn thing, please. But that's another one of those things that you can use. You can say like, look, these are the way that these things react. Like I can predict how these things should react based on the stimulus that we're giving it. And if you can do that and show it to them, they'll believe that you're actually telling them the truth and that you know what you're talking about. So just like Dave was saying, it's a very good buy-in tool to use with patients if you know how to use it. Like, look, I can predict this will be weak if I do this. And then you can show, particularly with facilitation, you can show them how it's strong if you don't put the pressure on it too quickly, right? If you just kind of slowly build up the pressure, they'll be nice and strong. You say, look, now I'm going to put the pressure on here nice and quickly. I expect this to be substantially weaker at this point. And then you show it to them and you say, look, we can probably fix this. We can change this right now. Flip on your belly. We'll do a little mobilization to it. Again, just a grade 2, mobilization. You don't want to stress the actual end structures. You just need some normal sensory feedback going through that reflex arc to change these things. And you go back and you retest it and you say, see, we know where it's coming from. Like right now we have proven this is coming from that spot. So whatever it is that's causing the problem here, that's what we have to find. They're kind of putty in your hands at that point. So.
I saw this presentation. I thought, it could be an easy one to overlook, but there's a ton of detail in here. And, this is basically something that we're practical, the things that we're sifting through, and to be able to quickly sift through and say, okay, it's not AXT or radiculopathy because I don't have this.
1 second, Ray.
And then I can move on to my differentials. And that's what they'll kind of look for. That's what Jim would look for. That's what we tend to look for, is your clinical reasoning ability to move between these differentials in a patient with pain and get down to what we have going on. Take care, Eric. Thanks a lot.
Yep, peace, boy.
As we go through this. So, and again, we will cover this in the future modules going forward, kind of get nauseam, but it's good I figured to have a discussion on it kind of talk about it a bit. You have, Jim's descriptions as well, which is actually very good. So it's just I figured it'd be a good way to kind of tie in what you're seeing in these presentations and how these models, theories come back in clinical reasoning. And I use, this model goes through my brain every day when I'm looking at people. Cool. Any questions before we turn Tanner loose on his question? If not, guys, have a great day. Hope this was helpful.
Thanks, Dave.
Yeah, no, my
Thanks,
pleasure.
Dave.
Thank you, Dave.
You have his
Oh, yeah, you guys take care.
Oh, actually, let me check. But he responded, I was emailing.
The more we talk about this stuff, the better. It's just the more that we bounce the difference between them.
Yeah.
As much as you can integrate this, it's gonna help us.
Yeah, we'll keep talking. I'll try and roll it in the labs as well.
It's good. Eric,